Good evening, chairpersons, ladies and gentlemen. This talk was to be presented by Dr. Trehan, but he was not well, so I have been given the task to present this talk. So I will be talking to you about the treatment options of the aortic aneurysms. I'll try to finish in time, so I'll just rush through whatever I have to say. So any aortic dilatation, which is more than 50%, then the normal has been considered now as aortic aneurysm. So if we classify the aortic aneurysms into thoracic, abdominal and thoracoabdominal, the thoracic can further be classified into ascending aortic and arch, and abdominal the descending thoracic aortic aneurysms. And thoracoabdominal aneurysms have been further classified in from 1 to 5. So if we see descending thoracic aortic aneurysms, so if distal to the subclavian, the type A is distal to subclavian till the 6th intercostal space, type B from the 6th intercostal space to the diaphragm, and type C distal to the subclavian till the diaphragm. And if we see the thoracoabdominal aneurysm, which they have been classified into 5 types, type 1 distal to subclavian to the suprarenal part, type 2 from subclavian till the bifurcation of the aorta, type 3 from the 6th intercostal 6th rib till the descending thoracic aorta, and type 4 is from diaphragm till the bifurcation of the aorta, and type 5 is from the 6th rib to the suprarenal aorta. And if we see the abdominal aortic aneurysms, they have been classified in their position in relation to the renal arteries, like infrarenal, juxtarenal, pararenal, and suprarenal. And as we have been discussing throughout the day, all parts of the aortic aneurysms have, whether it is thoracic, abdominal, or thoracoabdominal, have been dealt by the interventional cardiologist or the vascular interventionist. Only the ascending aorta, which is at the moment being left only to the to the cardiac surgeons or the thoracic surgeons, I would say. So coming to the aortic arch aneurysms or aortic root aneurysms, if the size is more than 5 centimeters, the indication for the surgery, and if the valve is not involved or the sinuses are not involved, then we try to preserve them. Or if the valve is involved, the sinuses are dilated, then we do either by the classical Bentall procedure or Cabral, or different techniques are there. So this, the aorta is replaced, and the coronary buttons are being anastomosed to the aortic arch, to the graft. The overall mortality in the different series has been from 2 to 15%, but present day I would say in the experienced hands, it's around 2 to 5%. The major complication of this procedure is anastomotic site bleeding, thromboembolism, pseudoaneurysm, and infective endocarditis. And coming to the arch aneurysm surgery has also become quite successful these days, with the operative mortality of 5%, with the profound hypothermia, with the usage of retrograde and antegrade cerebral perfusion, and with the major complication are still there. Here we have to do a stage surgery. We have to keep shifting our perfusion cannula from ascending aorta to the descending part. The major complications still remain, like the stroke, like encephalopathy, and these are the basic complications of the profound circulatory arrest and atherosclerotic disease. And surgery for the thoracoabdominal aneurysm for the surgeons still remains a challenge, because it involves a major replacement of the aortic and thoracic part of the aorta. So mortality in different series has been 5 to 20%, and recently the survival has improved when we are being able to selectively perfuse the renal arteries as well as the intercostal arteries. So we replace the descending thoracoabdominal aorta and implant the renal arteries as well as the intercostal arteries, depending on this. And the surgery for the abdominal aneurysm for the surgeons remains one of the easiest things to do. If it is infrarenal, you just have to put a graft, a bifurcated graft, And if it is a straightforward thing, I mean, you can just put a conduit, straight conduit. And minimally invasive, people have tried minimally invasive abdominal aneurysm surgery. I mean, if it is the straightforward thing, I would recommend one can do this, but still remains, a challenge. And if it is surgery for the extensive aortic aneurysms, what we call it as a mega aorta, starting right from the aortic valve to going till the bifurcation, this has been one of the most difficult things for the surgeon to do. The surgery is being done in stages. So once, in the first stage we replace the ascending part of the aorta. In the second stage, we deal with the descending aorta. The procedure, which we generally call it as elephant trunk procedure, where the free end of the aortic graft is being left in the descending aorta, which can be dealt later on. 30-day mortality of this procedure is 6 to 8%, and neurological complications are around 2%. And we have been discussing throughout the day about the endovascular procedures. The endovascular procedures have been developed as an alternative to surgery. They obviously reduce mortality and the complications related to the spinal cord preservations, but they still have its problems. The problem is protection of the arch vessels and migration of the stents. Accurate sizing and tortuosity still remains a problem. The landing zones, we have to have at least 2 centimeters or 20 millimeters the proximal and the distal ends, and large sheath size. At times, I have seen myself and experienced that the large sheath size and passing it through the femoral artery, especially in Indian subset, becomes a very difficult thing. I mean, we as cardiac surgeons or the vascular surgeons always, dread this if you get a call from a cardiologist or the vascular interventional colleague that you have to deal with this, because it becomes a real big problem to pass a device through the femoral arteries or the common iliac. And access site complications as another problem, and the regular surveillance is needed in these patients for the endoleaks. And these days we have been talking, and in fact doing this, the hybrid procedures, combining both the best of the both worlds. Combining the surgical part for the ascending aorta and for the descending thoracic aorta, a stent graft has been put. So it can be done at one stage or it can be done at the 2 stage. The early results are pretty good. It has a 1 year survival rate of 85%, 3 years as 73%, and at 5 years around 70%. So these results are pretty good, but long-term results are still to be seen. This is one of the procedure which has been done at Apollo Hospital in collaboration with Dr. Khanna, where we have put a graft of the great vessels, and Dr. Khanna has done the intervention and put a stent there. And this is what we are planning in the next phase, that as a hybrid OT, with this OT would be having a cath lab. This will be the ideal situation where we can do at the same setting, put a stent and do the surgical intervention at the same time and give the best possible thing to the patient. Thank you very much.
Thank you, Dr. Rajneesh. Since you have finished well in time, we have 1.5 minutes for question and answer. This was truly a masterly oration. Nobody could have given it in 8.5 minutes. Any questions from the audience? Anything, any comment? It's always good to have an audience participation. Regarding your last case which you showed, I think you did an ascending aorta to the bicarotid bypass and then you placed the graft, is it?
That's right.
Did you use a complete sternotomy or did you do with a mini sternotomy at the top?
We did a complete sternotomy.
Complete sternotomy. Right, because that is one thing which is coming in. If the anatomy is favorable, some surgeons are further trying to make it meaning by only limiting the incision to the manubrium or the upper part. And of course, if only the left carotid needs to be covered, then you can do a carotid crossover and then put the graft.
That's right.
Any questions from fellow panelists?
You did the intervention, that is the stenting first, and then you take the surgery.
We did the surgery first, followed by the intervention.
That is your
That is what we
mode of work. And this and this operation theatre, this hybrid operation theatre that you just now showed, is it already in function? And
No, it's the future thing. I mean, we're going to have it functioning within the next 3-4 months' time.
Excellent. Very interesting. Thank you very much. If there is no other question, you have a question?
This is regarding the last case. That was very interesting. I would just like, did you stage it? Was it done in the same day or after a gap to know the patency of the graft? Was it
No,
the
it
last
was,
hybrid?
It was a stage 1, and I
Yeah.
think the difference of how many, Dr. Khanna? I mean, how many days you did that? 4 days.
Okay.